Losing your erection right in the heat of the moment makes absolutely no sense in 2025. There is no reason for you to be suffering through this alone, frantically searching for solutions on the internet, looking for random medications, or seeing professionals who might not be the best fit to help you. In this video, you are going to understand the real causes behind why you are losing your erection, exactly what is available in terms of treatment. And the final treatment option I will mention at the very end makes it physically impossible for you not to get an erection and achieve penetration. So, stay until the end so you can understand what is best for you. Let's get into it. The inability to get or maintain an erection. That is the definition of erectile dysfunction. Now, I hear this all the time. I don't have erectile dysfunction. I think I'm fine because I can get an erection. I just lose it in the middle. That is erectile dysfunction. Period. It is simply at a different level or degree than the patient who has 0 degree of erection, the guy who says, nothing happens. I want to be intimate with my wife or my partner, and I had absolutely no erection. We are talking about severe erectile dysfunction there. If you lose it in the middle, that is moderate. If you notice your erection is just of poor quality, but you haven't lost it yet, that is very mild. You might not even think it fits the category, but it is very possible you are in that early stage. The fact is, regardless of the level you are at, the causes are very well defined. There is one specific cause I won't spend too much time on, which applies to men who have had their prostate removed. If you had surgery to remove the prostate, you may have had nerve damage right there next to the prostate, which leads to erectile dysfunction. That is very specific to those who have had surgery. Generally, for everyone else, there are 3 main reasons this happens. The first of them is vascular. You have a diseased blood vessel, so less blood is arriving at the penis. If you have been researching this, you understand that an erection is basically blood arriving at the penis. You have 2 cavernous arteries that carry blood there. If these arteries are clogged by a plaque of fat or calcification due to age, diabetes, or smoking, less blood arrives, and you won't have a quality erection. So, the vascular cause is one of the main ones. It is the principal cause after age 45 or 50. This is because you start to see the aging of that vessel, and due to that aging, the vessel loses its capacity for compliance and dilation. Less blood gets to the penis, resulting in famous erectile dysfunction. The second cause is hormonal. Your testosterone starts dropping. Studies vary a little, but generally, starting at age 30, production drops by about 1% per year. Further down the road, usually by 40 or 50, though nowadays we see it happening earlier, you start having low testosterone due to testicular failure or sometimes due to a deregulated axis. Things like sleep deprivation, anxiety, depression, and a sedentary lifestyle deregulate this axis. Your pituitary gland stops stimulating your testicles and testosterone drops. So, testosterone can drop either due to testicular failure or a system that isn't regulating properly. We see both very often. The fact is, when testosterone drops, you first lose sexual desire, the libido. Without desire, you don't have the will, and without the will, you don't have a quality erection. You get softness. If you don't have the will, maybe your partner sought you out, you forced it, and you couldn't perform. That is the hormonal cause. The last cause is psychogenic. This has been increasing drastically. In fact, nowadays, this is the most common cause seen. It is psychogenic erectile dysfunction, meaning it is all in the head. It is very closely tied to performance anxiety. What is that? It usually starts like this. For some reason, maybe you were tired, or you had a day where you just weren't feeling it, you didn't perform well. You lost your erection. From that moment on, you start thinking, man, next time I have to perform. Next time I cannot fail. When your wife or your husband seeks you out and foreplay starts, you are already thinking about your penis. You aren't thinking about anything else, not the smell, the hug, the kiss, nothing. You are only thinking about whether it is hard, whether it is not hard, if it's going to work, or if it isn't. You are driving to meet your partner, and you are already thinking about your erection. This hyperfocus on the penis is tied to an adrenergic discharge. You start with very high adrenaline. Adrenaline causes tachycardia and peripheral vasoconstriction. It pulls blood away from your hands, feet, and penis, sending it to your heart and muscles. Adrenaline is preparing you to run or fight. So, anxiety about performing kills the erection. I usually say that for many men, these three causes come together. A patient might have started with a vascular issue, then developed anxiety because of it, and since he is over 50, his testosterone isn't what it used to be. It is often multifactorial. The fact is that treatments are also very well defined with a high success rate. That is why you shouldn't be suffering from erectile dysfunction. It makes no sense. Before I talk about treatment, I need you to like this video and subscribe to the channel. Leave a comment below. It is good to leave your comment here. It is a safe area to comment. Everyone is suffering from the same thing. You will see countless people in the comments with the same issue as you, and that makes you feel calmer. So, the comments are important for everyone to help each other out. The treatments for dysfunction are well defined. I will separate them by cause. I will start with the hormonal cause, which is a more specific treatment. When you identify that the dysfunction has a hormonal driver behind it, and how do you identify that? You check testosterone levels, you check the whole hormonal axis, and if possible, you look at the history of that patient regarding testosterone. You notice the levels have been falling or the axis is deregulated. Then you propose treatment. If it is testicular failure, meaning the testicle doesn't work, you can see that in the lab results and you replace testosterone. If you have a deregulated axis, you regularize the guy's axis. You have clomiphene citrate, which is the main tool for this. You have an anastrozole for the patient who has a high rate of aromatization, converting too much testosterone into estradiol. You have HCG. So, there are means to stimulate the testicle itself or regularize the axis. You have other means to replace testosterone directly. You treat this guy, and gradually he recovers his physical disposition, his libido, and then his erectile function. When well indicated, hormonal replacement or testicular stimulation will treat this patient. Now, for the patient with psychogenic and vascular causes, despite the causes being very different from each other, the intervention treatment is rigorously the same. Aside from the fact that for psychogenic issues you can refer to a sex therapist, the physical intervention is the same. First line, oral medication. We are going to offer oral vasodilators. Tadalafil, sildenafil, L-arginine, citrulline. You have synthetic vasodilators like phosphodiesterase inhibitors, tadalafil and sildenafil, which are Cialis and Viagra. You also have L-arginine and citrulline, which are amino acids that boost the effect of these medications. Used in isolation, their success isn't that great, but together with these drugs, they do have very good success. Then we go to dosing strategies. You have the daily use strategy, tadalafil daily, 5 to 20 milligrams per day. You have the on-demand strategy, sildenafil 25 to 100 milligrams an hour before, or tadalafil 20 milligrams 2 hours before. You can adjust this along with the amino acids. You can even combine the two strategies. Take the daily dose and boost it on demand. You have to test doses. You test everything you can within this first line of oral treatment. What if you reach the maximum dose, or the patient comes in already taking the maximum dose, and it isn't working? Why doesn't it work? Why might tadalafil not work for you if you just have anxiety? Because the adrenaline you are releasing in that situation is so high, and its power of vasoconstriction is so strong, that the adrenaline wins against the vasodilation of the Viagra or Cialis you are taking. So you have erectile dysfunction even while taking the medicine. And for vascular causes, it might not work because the artery is so clogged that blood simply isn't arriving at the penis, so you have dysfunction even with the medication. Now, before we move on to the more invasive options, I know many of you hate the nasty side effects of these pills, or maybe they just stopped working for you. You don't want a band-aid solution. You want to fix the root cause. There is a bizarrely simple 7-second daily ritual involving a specific purple tonic that helps clear those blocked arteries and blocks the enzyme that kills erections naturally without a prescription. It's helping thousands of men get that youthful hardness back. I found a video that explains exactly how to make this at home. Point your phone's camera at the QR code on the screen right now to watch that presentation. I've also pinned the link to the top of the comments below. If pills aren't your thing, check that out first. The second line of treatment most used is intracavernosal injection. Injection into the penis. When we say that, Guys usually freeze and think, I am not doing that. No way. But it is actually very calm. It has its learning curve and adaptations, but it is a treatment with a high success rate. Remember that the first line of treatment resolves 90% of patients. Of the 10% not resolved there, you go to the second line. And intracavernosal injection can resolve 95% of those cases. Trimix, which is a combination of 3 vasodilators, the papaverine, phentolamine, and prostaglandin, has a very high success rate. You just have to find your dose. There are 2 ways to do this. You have the injection with a standard insulin syringe. You draw from the vial the pharmacy sends you, and you apply it to the base of the penis on the side. You insert the needle fully, inject, and you're done. It doesn't hurt. It is a very light pinch. You inject the amount of units decided with your doctor. The hurdle here is understanding you have to discover your own dose. Maybe you start with 10 units, then 20 units. Deciding the dose is important, and it is important that you have the antidote with you. Because if you have an erection lasting more than 3 hours, that is configured as priapism, a sustained, painful erection. More than 3 hours can cause lesions to your corpus cavernosum, and you can have permanent damage because of it. If that happens, you break the ampoule of the antidote, draw it up, and apply it to the other side of the base of the penis. Thankfully, the antidote works very well. If you applied a certain amount and had priapism, next time you lower the dose. If you had an erection for an hour and a half, that is great. Done. Intracavernosal injection is an excellent type of treatment. You also have application pens that look like insulin pens. The ampoule is inside. You dial the dose on the pen, place it on the side of the penis, click, and it is injected. It makes it more comfortable and discreet. Sometimes they are in short supply in the market, but it is a good form of treatment. Still within the second line, you have intraurethral gel. It comes in a specific applicator. You put the gel in the urethra at the glands and pump it in. 5 to 10 pumps, half an hour before relations. The problem with the gel is that it has a success rate around 65%, and it is expensive. The pen costs a lot, and it has a limited number of pumps. So, if you use 10 pumps per session, you only get a few uses. It is considered a deeply expensive treatment with a lower success rate. I don't like prescribing it much anymore because for many patients, they make the investment and it doesn't work. When you have erectile dysfunction, every false step impacts your head. But some patients want to try it to avoid needles. If we try it and it doesn't work, we move on. If nothing worked, you didn't adapt, you had too many side effects like headaches with pills, or you couldn't handle the injections, the last stage of treatment is the penile implant. As I mentioned at the start, here we are talking about 100% resolution. You will not have problems with erections ever again in your life. You take that burden off your shoulders. Yes, it is a surgery. We are talking about a much more invasive treatment in a surgical center. We place 2 cylinders in your penis, one on each side. This prosthesis can be the malleable or semi-rigid kind, where your penis stays permanently rigid, but you can bend it. You can bend it down to put on pants or shorts. At the beach, you adjust it to the side in tight swimwear. You can live calmly with a semi-rigid prosthesis. It is always ready for an erection. The prosthesis is sized to your penis, so it doesn't increase the size, but if done correctly with fibrosis release, you maintain your size. You don't lose size, which happens naturally with ED. Now, does it destroy the corpus cavernosum? You create a tunnel in the corpus cavernosum, but you have tissue on the periphery. The prosthesis sits in the middle. If you have some blood flow left, the penis will still engorge with blood during pleasure, thickening over the implant. If a guy has severe vascular damage, 72 years old, diabetic, smoker, he might not get that natural engorgement, but he will be able to penetrate whenever he wants, as many times as he wants, without the hassle of pills or injections. Many people complain that other treatments take away the spontaneity of sex. Stopping to take a shot or a pill kills the mood. The prosthesis gives you back that spontaneity. Beyond the semi-rigid, you have the inflatable prosthesis. This has 2 inflatable cylinders in the penis, a reservoir in the abdomen, and a pump device in the scrotum. You squeeze the pump to inflate the prosthesis when you want to have relations. You have sex, and when you are done, you press a release valve to deflate it. If you want to continue, you continue. If you want to stop, you stop. This returns the power of decision to the patient. You maintain sensitivity, you maintain pleasure, you maintain orgasm, and you ejaculate. It is an excellent form of treatment to give a patient his sexual life back.